start with stage 1 in PJI. We'll start with the point where Dr. Yuvraj Bhai left. So two-stage revision is still considered gold standard treatment for chronic PJI. As we all know, gradually single-stage revision is gaining popularity, but I'll still consider two-stage revision is a gold standard treatment for chronic PJI with good success rate. So if you see four most basic principles for treatment of any infection, the first one is a source control, second one is identifying the organism, third one is targeted antibiotic therapy systemically as well as locally, and fourth one is optimization of the host. So if we see the chronic PJI, the only surgery which can offer all four simultaneously is a two-stage revision procedure. So in my philosophy, as Yuvraj Bhai said, once biofilm is mature, you cannot eradicate it completely. So DAIR procedure or debridement is a race against the time. Once you lose that time, you are no longer can save the implant. So any infection presenting beyond early post-operative period, for me it's 3 to 4 weeks, should be considered as an indication for stage 1 or two-stage revision. Theoretically, failed DAIR, chronic PJI with or without discharging sinus, resistant organism like fungus, MOTT or multi-drug resistant gram-negative bacilli, implant loosening and compromised soft tissue envelope. Microbiological diagnosis, we all know identifying a bug before going in is extremely important. It can be achieved with gold standard culture methods or very recently used commonly PCR-like BioFire. Getting a bug before going in is extremely important for 3 reasons. You can start targeted antibiotic therapy as soon as you complete the procedure, or even you can start in certain resistant cases before going into the procedure. Mixing the antibiotics in cement spacers for local delivery and explaining the prognostic value to the patient to identify the bug is extremely important. Literature is divided on culture negative PJI. Still there are literature which says that results for culture negative and culture positive is same, but according to me, a culture negative PJI results and outcomes are poorer. Literature heavily supports the addition of local antibiotics for treating the knee PJI. I currently use Vancomycin, Colistin, Meropenem, tigecycline, and amphotericin in various conditions. I use 2 or more antibiotics in my cement spacers. I use 10% of powder volume of cement. I always add an opposite group of antibiotic to prevent the superinfection. Hand mixing with maximum porosities. For gram-positive cocci other than vancomycin resistant cases, vancomycin is a drug of choice in cement. For cases that are vancomycin resistant, mostly enterococcus, tigecycline or daptomycin is a drug of choice. Gram-negative bacilli, when they are sensitive to meropenem should be used. Gram-negative bacilli, when they are resistant to meropenem, tigecycline or colistin should be used. Fungus other than molds like aspergillus, conventional amphotericin B should be used. Aspergillus and other molds, voriconazole should be used. NTM or MOTT, we don't have anything in powder form, so omecacin liquid form can be used. When we are not knowing the organism, we should try to cover at least gram-positive, negative, and fungi. Cement spacers, we all know there are 2 types of cement spacers available, articulating spacers and static spacers. In the market, we currently have ready-to-use cement spacers that are pre-sterilized, but they have fixed antibiotic contents. Mold-based, prepared on table. These spacers are like Yuvraj Bhai using his own spacer. These spacers can be made on table. You can choose the antibiotic as per your culture and sensitivity, and you can use in larger gaps also. The most modular and time-tested was handmade spacer. We are still using in some cases, but most of the cases now mold-based spacers. Static spacers, they are useful in when there is an absence of stabilizing structures, extensor mechanism, and whenever you want a coverage by plastic surgery through flap. So one of the indications of static spacer, I always say, in absence of patella tendon, static spacer with shortening and flap coverage should be attempted. We have done good number of cases where the patella tendon was completely necrosed. In those cases, if you try to attempt dynamic spacer without shortening, there are more chances of failure, and those patients then ultimately end up with amputation. Articulating spacer, as I said, I use reusable silicone mold based cement spacers prepared on table, available in left and right and multiple sizes. So these spacers are a copy of one of the implants available in market. So it mimics the exact implant, gives a smoother range of motion and longevity also. Intraoperatively, most important message intraoperatively is to removal of complete removal of necrotic tissue, complete removal of implant, and complete removal of cement debris. You can see one of the pictures, earlier surgeon has left patella mentioning that the poly should not be removed, but according to me, all implant, including poly, should be removed completely. Use of chemical antiseptic solutions. There are various chemical antiseptic solutions you can use. I use 9-liter saline, 3-liter saline with normal saline, 3-liter with betadine, 5% volume by volume. Post-operative antibiotic protocol, all patients in our setup given total 12 weeks of antibiotic, 6 weeks IV followed by 6 weeks oral. Usually you should give 2 antibiotics and should not give only one to avoid avoid resistant bacteria, and to be decided by ID specialist. Central line or PICC line used in all patients. Every 15 to 30 days we should assess for LFT, RFT and inflammatory markers. There's a lot of debate going on around regarding the holiday period or should not be a holiday period after ICM 2025. But we currently follow holiday period in all patients. Minimum 3 to 6 weeks is offered before re-implantation. As we earlier said, patient optimization, duration between 2 stages provides excellent time interval for optimization of patients physically, psychologically, and in financially resource-limited countries like India, even finances can be managed in between the procedures. Post-op physiotherapy protocol, all patients with articulating spacers are mobilized within 24 hours of surgery. First preference is given to the wound healing rather than mobility. So we wait for at least 3 to 6 days before we start knee ROM. Once the wound looks settled, we start with knee ROM gradually in bed, and after stitch removal, we allow them to go for high sitting also. So most of the patients, we continue spacer up to 6 months, sometimes up to 9 months. The longest follow-up, Dr. Ashish said, sir, is having around 5 years, patients still on spacer. Re-implantation protocol, there are no fixed protocol guidelines given for re-implantation protocol. CBC, CRP, most of the times, even if they are normal, they can have a recurrence. So before going in for the second stage, all patients should be aspirated, synovial fluid, routine micro and culture. Even though routine micro and cultures are normal, you cannot predict a successful outcome or you cannot prevent a recurrence. So I would like to invite you all for the first of its kind of PJI Con 2026, managed under the banner of Indian Arthroplasty Association. It will be at Goa, Marriott Panaji on 11th and 12th July. And Dr. Yuvraj Bhai and I will be among the organizing committee members. Thank you.